sometimes I find some muscles like infraspinatus, which are key to modulate all the muscles in the upper limb. But surprisingly, what I found very repeatedly is that some muscles that for musculoskeletal patients should be very local, like adductor pollicis or first dorsal anterosis, are really relevant in a neuro patient.
CPD Health Courses. Dry needling training for health professionals. Online theory plus face-to-face practical. Start your training today at cpdhealthcourses.com.
Okay, welcome everyone to this podcast by CPD Health Courses. We're once again joined by an expert in the field, Dr. Pablo Herrero, PhD. He's a physiotherapist from Zaragoza in Spain, and he teaches dry needling at undergraduate level at San Jorge University, I hope I said that correctly, and postgraduate levels as well around the world. He's developed the DNHS technique, which is the dry needling technique for hypertonia and spasticity. It's a dry needling technique to treat spasticity, which he has expanded to different countries all around the world. We're really excited about this topic because we haven't had anyone talk about this subject at all on our podcast series. So presently, Dr. Herrero is Vice Dean of the Physiotherapy degree course and Director of the iPhysio research group at San Jorge University in Zaragoza. He is also President of the Association for Research into Motor Handicap, otherwise known as ADIMO, the acronym for it, and is about to become a member of the editorial board of the recently created Journal of Invasive Techniques in Physical Therapy. Pablo, welcome to our podcast. It's a great pleasure to have you on our show.
Thanks very much for letting me have this opportunity.
We're going to start with our first question. So how did you become interested in dry needling?
Well, when I just finished my physiotherapy bachelor, one of my lecturers told me that Orlando Mayoral was going to teach the first edition of a dry needling course in Zaragoza, and he had very good references from Orlando, so he encouraged me to attend the course. At that moment, I was working with musculoskeletal patients in private practice and with neuro patients for the government, so I attended the course because of my interest in pain and musculoskeletal patients. But when Orlando was explaining the mechanisms of dry needling, I discovered a link to neuro patients, and some ideas appeared in my mind as I realized that botulinum toxin was acting in the same target structure, the end plate zone. At least in Spain, people tend to differentiate a lot between musculoskeletal patients and neuro patients, and in my opinion, both areas should be closely related, that we must consider central nervous system involvement in musculoskeletal patients. For example, when we speak about chronic pain. But also, we must not forget that neuro patients have also a musculoskeletal system. Summarizing, I define myself as a specialist in invasive therapies, which is the Spanish term for dry needling related techniques, although I'm aware that the term invasive in English may be more related to surgery. What I most value from having this broad approach treating neuro patients is that it has helped me to understand a lot of things related to dry needling in musculoskeletal patients, and also the opposite. So I'm continuously transferring knowledge from one area to another.
Okay, I got you. Excellent. So Orlando Mayoral, in fact, we interviewed him last year about his work, and great work that he did with some knee arthroplasty, the research that he did, which was wonderful. Okay, so that's great. We've got your background. Now, actually, the first time that I came across your work was when I saw a video. It's on your YouTube channel, and we'll put some links to that once we've got this podcast recorded. But I saw this video about a year ago, and I was shocked. Literally shocked when I saw it, because the results were immediate. So what happened was, you've got a middle-aged lady. She's sitting on one side of what looks like a treatment table. She'd suffered a stroke, I think, and was sitting at the table with 4 plastic bottles in front of her, and actually to one side. And she was tasked with simply moving the bottles across from one side of the table to the other using her right arm. Now, the distance that she had to move the bottles was about a couple of feet or 60 centimeters. Now, at first, she really struggled. She found it hard to oppose the thumb and index finger and grab hold of the top of the bottle. And she found it very hard to let go of the bottle, even after she'd got hold of it and put it over the other side. She found it hard to let go. So what happens next is that it looks like you were you needled her flexor carpi radialis, maybe what looked like that, and adductor pollicis in her thumb and in the right arm, and immediately the effect is instantaneous, which is what shocked me. She had much better control. She didn't drop any of the bottles. She could do the opposition of the thumb and index finger much better, and a lot more coordination and a lot more confidence in her movement. How did you explain this? How does that happen?
Well, this is a good question, as this has to be with the evolution of my thinking also these past years. When I started to use dry-needling and we published the first case, I was just considering local effects on end plate zone, and considering that, I think that some way dry needling would decrease excessive muscle activity of some patients through mechanical rupture of dysfunctional end plates. In this first study, we found a relevant result, which was that when performing fast movements to the upper limb, the threshold of stretch reflex had increased significantly. This made me reconsider my hypothesis, and I started to consider central effects of dry needling. After this first experience, I've been treating patients with different etiologies, and I've realized that it depends more on some components than in the etiology itself. As an example, one of these patients allowed me to identify clearly these two components, which I classify as biological and central nervous system dependent. This patient had a lot of hyperactivity that decreased for about 3 days after dry needling, but changes in the general organization of movement remain for a longer period. So, when we assess a patient, we try to consider these two components to predict the possible evolution and how long the effects are lasting, as this is always something that the patient or the family is asking, and we need to give a good reply to them. So, replying to your question, I think that the results in this patient were a combination of local decrease of muscle activity, but also a reorganization of movement. Because of this, we decided to start a pilot study with only 2 patients to analyze electroencephalographic changes, and we found changes in some cortical areas that may explain this, although we cannot establish a cause-effect relationship because it was a reduced sample size.
Okay, so because there was only 2 people in the pilot study, but you aim to increase that presumably.
Yeah, we would like to, but it also has a lot of problems to get patients here to university to use equipment. Mm-hmm. So in the research lines, we are trying to use other more portable equipments to measure, but we are trying at least how to develop new lines to study the underlying mechanisms of dry needling, which is very important for this specific type of patients.
Okay. So you need more patients. That's great. I look forward to hearing more about that. So you've developed, as I said before, the DNHS method of treatment, where DNHS is an acronym for dry needling for hypotonia and spasticity. So, and you've even trademarked it, so got a registered trademark next to it. Tell me why this is specific or unique in terms of dry needling. It's a protected name?
Well, the idea to register this name or this brand is because, as in other specific techniques with their own brain or name, this would be useful to remark that it has differences than when applying for musculoskeletal patients, although I prefer to look for an acronym that define the technique and methodology and not to restrict to my name, because I'm aware that new research will help to develop this specific application of dry needling, and this evolution will be the result of other people finding, so I consider this is more dynamic to invite people to contribute with research. This is also a trademark, or this was the idea, because I have had the bad experience of people that just attended one of my courses and was teaching bad quality courses, causing adverse effects to patients, as in other dry needling courses may happen. So I thought that registering this trademark would help to make sure that people attending a DNHS course would be sure that they could find a high quality course. So this is the idea behind this decision. Yes. Also. My clinical experience led me to define a specific protocol for assessment and treatment that has also evolved every year with the new findings, because as I told you, my hypothesis, it was very basic, but we have been finding a lot of things and we are changing this protocol. We are renewing according to the new research. So the latest version, which is completely updated, was recently published in the book Advanced Technique in Musculoskeletal Medicine and Physiotherapy that was published by Elsevier recently. This book has a chapter with all published and non-published data to help the reader to get a deep knowledge of dry needling in neuro patients.
Yes.
So dry needling of muscles, in my opinion, is very dependent on anatomy. So if you are a specialist in dry needling, you will know how to properly place the needle, how to reach the muscle, how to be safe during dry needling. So it's not just putting a needle in a muscle, but for example, for neuro patients, we can apply a specific assessment and treatment method taking some considerations into account that we don't usually have for musculoskeletal patients. For example, we put the muscle in a submaximal stretch position. That would be painful in musculoskeletal patients sometimes, but in neuro patients, it helps a lot to differentiate the trigger points, to really know when we are achieving the result, because the muscle relaxes and we are aware of this relaxation. So what I mean is that the difficulty for me is to make a clinical reasoning of which muscles to treat, or how you can be more specific to dry needling trigger points when you don't have some references. For example, in a neuro patient, they don't have tender spots if they don't complain of pain. You have to use other criteria. So it's not just putting the needle in a muscle, it's taking into account a proper or a specific evaluation, treatment, to select, to have criteria, all these things, and being updated with all the recent research we are doing and with all the clinical experience that we find attending patients.
Okay, I got you. So what you're saying is you got to differentiate the musculoskeletal type of patient with a neuro patient. It's not exactly the same. You're doing different assessment techniques to establish where you're going to do the needling. Now, is there any particular caution or adverse, not adverse, or contraindications that one should think about when treating the neurotype patients as opposed to the musculoskeletal ones?
Yeah, for me, one of the most common things that sometimes is not so often in musculoskeletal patients is that usually neuro patients are taking some anticoagulant drugs. So this is something you have to take into account, because for superficial muscles, it won't be a problem, but for the muscles, it may become a problem. And anyway, you have to be aware of the dosage that they are taking to avoid any risk. And also they have some sensitive impairment. So this is something also to consider, specifically in the first session. So you have to be cautious. And there has been other clinical findings. It's not properly demonstrated, but I have had the possibility to share this with some neurologists, and they don't find any relationship, but I always like to tell in the courses that if patient is suffering epilepsy crisis, we should tell the patient that have a look if they are increasing or making worse, because I had 2 experiences of neuro patients, although they were with pain, that increased the epilepsy crisis. So sometimes I don't think this is a contraindication, but at least we should be cautious and let the patient know in a consent informed sheet or whatever. Okay?
Okay, so that's interesting because I've always wondered about that one, because epilepsy is listed as one of the relative contraindications that for dry needling. And I've always wondered whether that is because if you needled somebody and they have epilepsy and they had an epileptic fit while they had the needles in, that's a problem. Okay. Now that probably might not be a problem if they're controlled, they've not had a fit for a long time and so on. Or is it in fact the needling that's causing the epileptic fit in the first place? Well, what's your thoughts on that? You're alluding to that before.
Yeah, I'm not sure because I had two experiences, but for example, I had a very, very clear experience. So I was treating the quadratus lumborum because of a cerebral palsy children, a child who had back pain. He was, I think he was 20 years old, so he was not a child, he was an adult. But when I was doing that, just when I inserted the needle into the trigger point, the patient told me, okay, I have felt my pain, this is familiar, but he also told me that he was feeling that in 2, 3, 4 seconds, he was feeling like he's having a epilepsy crisis, but not this big epilepsy crisis. This was just a very small epilepsy. So I was doing this intervention again and again because this was something very controlled for the patient. But after some sessions, he told me that the amount of crises were increasing and he has a very high medication. So we left doing dry needling. So maybe
this
is the only very clear case that was related because after 3-4 seconds, the patient felt this crisis. So,
okay.
But in the rest of them, I haven't found them.
Okay, that's interesting. Okay, so back to DNHS. What sort of patients are going to be helped by these techniques?
Well, my experience all this time as a clinician, as a researcher, is that results don't depend mostly on the etiology. So it depends more on the patient's characteristic. So a good assessment may help to predict which patient may benefit more. I think that this technique is very good when we assess a patient and we find that the resistance to passive stretching that we could define as hypertonia is mostly from a central or neural origin. I mean that from a clinical point of view, tests are positive when we increase the stretch velocity. This is usually related to the achievement of good results with dry needling, as dry needling will provoke a considerable decrease of this muscle hyperactivity, and also, which is very important, a stretch reflex modulation via increasing the threshold. This is my hypothesis because I haven't demonstrated this, but this is how I think it's working.
Okay.
Another important characteristic, which needs also further research, is regarding the central organization of movement. Obviously, this is very related to cognitive patients' characteristics. So, usually patients that can have a high functional activity and have good cognitive skills may benefit mostly because they can also do other complementary treatment to benefit from the dry needling effects.
I got you. Okay, that's great. All right, my next question. I'm really looking forward to the answer to this one because I think this is at the heart of DNHS. So, in another video I saw a couple in my research before this interview, also on your YouTube channel. You treat a lady who has had a traumatic brain injury. She's walking along a corridor, and you're obviously videoing this and so on. And we watch her gait as she's and her balance as she's walking along the corridor. It's not great. A lot of swaying. She's using her arms to balance. Her right leg does all the work. The left one is flexed at the knee and the hip behind her. And then you apply some needling to rectus femoris, adductor longus, extensor hallucis longus, and tibialis posterior, and the medial gastrocs. So, in the leg generally, and the thigh and the leg. So, she improves dramatically again following the dry needling session when she starts walking. But what I wanted to know was how is DNHS different from, let's say this patient went to a dry needling therapist that wasn't trained in DNHS method, how would they differ? Is the needling techniques, are they different themselves, or are you still trying to get twitches out of the trigger points, or is it the muscles that you're treating and the order that you treat them that's different? Which one is it, or is it both?
Well, I think that there are a lot of things to comment regarding this question, because
sure.
The basic part of the dry needling may be the same, because the muscles are in the same place. The approach of the needle can be the same. So, as I told you before, if you are a specialist in dry needling, you won't have any problem to reach the muscle, to dry needling safe. But when we're approaching neuro patients, there are a lot of differences. For example, because when we start to make the assessment to select which are the muscles we want to do dry needling, we have to follow a specific evaluation protocol, because, for example, the main criteria for musculoskeletal patient, which is a tender spot in a top band, is impossible for this patient. So we try to use some alternative criteria, like having an increase in the volume in some superficial muscles, or we try to make some specific tests in the vision, because we can feel how there is excessive activity in some points that may be related to the end plate area. So if we start with a good evaluation, it would be easier to find where I should put the needle exactly, because what we have realized, comparing with the botulinum toxin injections, is that a physical therapist needs to be very specific, because if you are just a bit apart from the specific area, you are not going to have responses. But as you were also saying, we are trying to look for local twist responses, as this is a good clinical indicator of clinical effectiveness. There are a lot of studies supporting this, but we have also found sometimes some more general responses, like global twitch response, we call, because the responses sometimes are very clearly in the muscle, like a local twitch response, but sometimes the whole muscle may contract, or some other muscle. So this is not so often, but sometimes we find this. And independently, if there is a local or global twitch response, what we can feel is that the muscle relaxes just after the dry needling. So when a muscle has a spasticity or has overactivity, we can really check that the muscle is being well treated, because it's relaxing. We can feel this decrease in the tension, and because of that, we also do the treatment in submaximal stretch position, because this allows the clinician to feel a resistance, and just when this resistance is decreasing. And apart from all these things regarding evaluation and treatment, for me it's very important the clinical reasoning behind all this, because when you have a musculoskeletal patient, you have a clinical reasoning, but when you have a neuro patient, you can have some other clinical reasoning, although we don't have a lot of research to support this. So sometimes we can understand the patterns of pain published as a reference to know which muscle can be related by the referred spasm or referred inhibition. But sometimes we have found that some muscles are key, like, for example, adductor pollicis or the first dorsal interossei, because they modulate the whole activity in the upper limb. So there are some differences that we don't have strong evidence now to say what's happening. So this is also a good point to work for the future.
Okay. It seems the way you approached the treatment for this lady was very holistic. You looked at her as a whole picture, saw her walking, you saw what the problems were, and someone skilled like yourself can have a look at her and say, well, this muscle would probably be tight, this muscle would be more relaxed, and so on. And, and your treatment would be focused in on looking at her as a whole, rather than she's come in with pain somewhere. It's more about her function. Would that be right?
Yeah. I think that when we face a patient, a neuro patient, the first thing we are doing in the protocol is to make a functional evaluation, because it gives you a general overview of which are the muscles that may be interacting more with the activities of the patient. But what we also do after that is to make some specific orthopedic tests to check, for example, in this patient, when you analyze, you can say, okay, perhaps adductor longus may be involved, perhaps gracilis, but sometimes it's impossible to realize just with functional analysis. So sometimes you can say, okay, I'm going to perform some orthopedic tests. So, for example, with knee flexion or knee extension, so sometimes you can realize if some muscles can be more affected or maybe more relevant. So what I always say to people that is going to do drain needling neuropatient is that usually you will find a lot of muscles to do drain needling, because you want to decrease activity, or you want even increase activity, because we know that it also works for weakness muscles. But it will depend on the patient's tolerance, because if you realize that the patient is only going to tolerate 1, 2, 3 insertions or 3 muscles, you have to clearly set a priority of the muscles to be treated. So the most relevant to the less relevant. Yeah. But other times, people tolerate a lot. So you can do a lot of drain needling. But from a clinical reasoning, you have to make functional evaluation, a specific test, and then set a priority and start working. Although this was a case where I only had the opportunity to treat this girl for once. So this is different than when you treat a patient every week, because sometimes I recommend just to treat the muscle you think more relevant, just to check in real life what's happening, and then to try to check other muscles like where you are testing now the different effects. Or sometimes when people improve and change the pattern of movement, you realize that sometimes other muscles that were not relevant are overloaded or are increasing activity. So sometimes it's not so static. So it's changing through the time.
Well, this is a really interesting conversation, Pablo. Every time I listen to your answers, I think of more questions that I hadn't thought of before. So we could go on for hours, but we won't. But I just go back to one thing I remember when you just answered that question. So what you're saying is we've got to look for the key muscle that perhaps is involved, rather than, of course, there could be many muscles, as you say. And the advantage of doing that, if I'm right, is that you can treat that key muscle or 2 muscles, and then you see whether there have been any changes. The problem with treating multiple muscles, 10 or more, is that you don't know which one of those was the key.
Yeah. So it depends on, for example, in my experience, sometimes when I attend a course and the patient wants to be treated and to have the biggest effect, so sometimes if they tolerate, I treat a lot of muscles according to my priorities. But in the clinical setting, if I'm going to visit them for different weeks, I try to obtain this information because this is very relevant. And sometimes I find some muscles like infraspinatus, which are key to modulate all the muscles in the upper limb. But surprisingly, what I found very repeatedly is that some muscles that for musculoskeletal patients should be very local, like adductor pollicis or first dorsal interossei, are really relevant in a neuro patient. So this is also a challenging question for researchers, because sometimes we find things are like in musculoskeletal, but sometimes not. So I think this is a good work to do there.
Great. Well, which is obviously why you're interested in this subject, the differences in there. So, I mean, this population that you're able to help is a lot of people. Many people suffer brain and spinal cord injury around the world. And according to the journal Injury Prevention, the incidence of total brain injury is 200 per 100,000 people, or traumatic brain injury, I should say, is about 0.2% or 200 per 100,000 people. So that's quite a lot of people if you look around the world. So it's a serious health problem for governments and healthcare policymakers. One of the main problems for patients might well be the spasticity as a result of their brain injury, so which of course is in the title of DNHS. Tell us about spasticity, because spasticity has an important relationship to what you describe and you've mentioned in your research as RTPM, or resistance to passive movement. What is that?
Well, this is really a difficult question to reply. I thought it was easier until I started my PhD under supervision of Professor Dr. Anand Pandyan at Keele University, because he made me think a lot about this, and I was surprised to discover the difficulty to define this phenomenon. When I refer to spasticity, I usually try to summarize as the central component of hypertonia, but it is not really like this, as there are other factors contributing to it. But from a clinical point of view, I consider that the main point is to try to identify any central component of hypertonia, as dry needling will help these patients, although sometimes we don't know well the exact mechanism. One of our collaborators is doing a research with members of my research group in spastic rats at Anahuac University in Mexico, and I hope this helps to solve some of our doubts regarding this effects of dry needling in spasticity. And we also are developing here some research with Dr. Comas Soriano at Toledo Physiotherapy Research Group. But summarizing from my mind, when I just started to do dry needling, I was focusing a lot in spasticity because everybody was speaking about spasticity and my concept of spasticity was really different. But now I'm more looking to the general function, because sometimes spasticity can be related to the function, but sometimes it's not so related. And clinicians usually tend to mix spasticity and to use a lot of terms like it was spasticity, although it's not. Even in the journals, you read spasticity or the measurements of spasticity, like the Ashworth scale, which is not really measuring spasticity, it's measuring hypertonia because it's not considering some specific aspect of spasticity, like the velocity dependence or some other issues. So I think that sometimes, even if you have this clear in your mind, when you write in a journal, you have to make it also clear for clinicians reading it. So I struggle with this a little because, for example, my PhD director always criticizes me when I write spasticity and all these things. But on the other hand, I think I have to write this to let people understand this is like the central component. So this is sometimes a bit difficult for me to feel the two objectives, to let it know and to be really thought of when I'm writing.
Okay, so I guess, my next question is made redundant now by your answer, because what you're saying now is that you're moving away from spasticity a little bit and thinking about function, although when you're writing, you're talking about spasticity because that's the orthodox explanation. So let's say that forget spasticity, because what I was going to ask you is how are you going to measure that so that you can see whether dry needling is helping or not. But let's say that we're not thinking about spasticity at this point. We're thinking about function as to a degree of how somebody has improved. So you would say, like in the video, the one we explained before with the lady with the 4 bottles, you would say that her function of maybe thumb and index finger opposition has improved, or what's the measurement tool that you're going to use for function?
Yeah, I want to differentiate between the real life or the way of like a clinician can evaluate and when you have to publish things. Because, for example, when you treat patients, you can record a video, you can see that the movement is better, the quality of the movement is better. The patient also can describe that she feels better, she feels more comfortable, she feels more stable. But sometimes when you move to a gait lab and you want to measure, sometimes it's very difficult to address all these changes, and specifically when they have to be with the quality of movement. So sometimes we are using some scales like Fuel-Meyer for upper limb, for example, or some other clinical scales, but they also have some restrictions from my point of view. But this is the only way we have to measure the function. So we are using these scales.
Okay, all right. So a couple of other terms that are used in this type of patient and with trigger points generally is contracture and, of course, hypertonia. So how do they differ? What are the definitions of those with respect to perhaps comparing those to spasticity?
Well, hypertonia for me is a more general term than spasticity, including it, because hypertonia can be defined clinically as resistant to passive stretching, but this resistance may come from a peripheral or biomechanical origin, or sometimes it can be central or neural. So in clinical terms, there is always some degree of overlapping of these two components. So when we speak about a contracture, it's because the tissue is shortened, we have a structural shortening of the muscle, or the tissue has suffered some kind of remodelation. So if we apply dry needling, we won't have effect, except if there could be some neural component overlapping. But if there is a big contracture, we won't find good clinical results. So this is also a good thing, because I'm used to use this technical word of contracture, because in Spanish it means like trigger point, but when you move to English, contracture is like a shortened muscle. So sometimes when you want to write in English, it can be a problem. Also, it happens with invasive, because invasive we think here is like just putting a needle, but sometimes invasive could mean, I think, more surgical procedures. I'm not very sure, but this is also different from Spanish. But we can say that when we find a high biomechanical component of hypertonia, is because we have a contracture, and contracture is going to need other type of physical therapy treatment, mainly based on serial casting or orthosis or this kind of, or even surgery. But despite of this, we must consider that dry needling for these patients, as we have had many cases, if we treat and they have some central component of hypertonia, even with a slight decrease of this muscle activity, we can help the patient very much. Because, for example, I have had a lot of patients with a lot of contractures, but just decreasing the central component, they can be more relaxed, they can wear the orthosis. So this is something important to consider for people giving the treatment to these patients.
Yeah, well, absolutely. And I think that the explanation that you made there with invasive and contracture is spot on. That's what I would think of as contracture, that you're looking at a whole muscle. But then again, sometimes that's referred to as with a trigger point. That's the explanation for a trigger point. So let's have a look at what is available at the moment. Let's say we didn't do dry needling, but what is the medical treatment now for someone with a traumatic brain injury or a stroke or something like that, where there's been some medical treatment? What would that be, and is it pharmaceutical? What are the side effects for that? Because there must be a lot of patients who have only that option at this point.
Yeah, well, I'm not a medical doctor, but the main treatments that these patients are receiving, or the research we have up to date, are related with the infiltration of botulinum toxin, but also with some oral antispastic drugs or even baclofen.
Okay, so there's a lot of medication there, and Botox, of course. So do these drugs work at the moment? Are patients getting good results with them?
Well, sometimes it works and sometimes not, like other therapies. I mean, I have found some cases where patients had adverse effects for botulinum toxin. So if they can receive this treatment, an alternative treatment to offer could be dry needling. And I think that it should be a good possibility. So we should work on demonstrating it has good effects, because sometimes it could be a complement or even an alternative, like in this case. For example, I have found a case of very affected patient with only a residual movement of the thumb to communicate that when received botulinum toxin infiltration, they suffer weakness for about 3 months, impeding them to communicate. So, for example, for these patients, if you just do dry needling in this muscle, you decrease the activity, but you don't provoke so much weakness, so they can maintain the function of this finger to communicate. So I think that dry needling may have very good and positive effects. And I think that botulinum toxin sometimes works very good, although it also depends on being properly indicated and injected with precision, because sometimes in the clinical setting we realize that it's not properly indicated or is not injected with a lot of precision. So from my point of view, dry needling can be very helpful for these patients, sometimes isolatedly, but some other times they can combine, because I think it's important to have open minds and consider that patients would benefit of other treatment options, and this is showing very good clinical results. So if it's properly indicated and applied, it can help the patient. So, for example, I would like to give you some other cases or some examples that dry needling may substitute botulinum toxin or even be combined. Because I think that people listening to the interview will understand my thoughts better.
Sure.
So, for example, I was remembering, if you have a look to the mechanism of action of botulinum toxin, sometimes you can decrease the activity a lot, but after a time, for example, several weeks, the muscle is going to have overactivity. And again, so perhaps one possibility is to do dry needling, because you can inject again botulinum toxin. So this could be a good complement.
Yeah.
Okay. Or sometimes, if you want to do injection in a lot of muscles, you can go over a dosage. So sometimes you can inject botulinum toxin in some muscles and do dry needling in others. So I think that there are a lot of possibilities, and they should be available for the patient.
Yeah.
So I understand that there is a lot of research on botulinum toxin effectiveness, and this looks like the unique option for all these patients. But when you analyze this evidence, it's mainly related to the decrease of hypertonia measured with the Ashworth scale or so. So it's not so strong evidence from a clinical point of view. So we are starting this year, we are starting a thesis about a comparison of this botulinum toxin infiltration and dry needling. So I hope this helps to really know the comparison between these options, because in my opinion, there is also one thing to improve in the studies carried out with botulinum toxin for pain, as they usually compare a single treatment. This is something I don't understand, because we don't work the same in the clinical setting. If you inject one single session of botulinum toxin, you are going to visit the patient after 6 months, but when you do dry needling, you do repeated treatments. So I think that the comparison should be made based on clinical application, and because of this, in this thesis, we are comparing a single botulinum toxin injection with 7 sessions of dry needling. This is more clinical approach. No?
Yes, absolutely. So you're going to actually run a study about the botulinum toxin and dry needling. So you're actually going to do a study where you're looking at both therapies and comparing them, are you?
Yeah, we are trying to do that, but we are finding some resistance regarding the ethics committees because we have to demonstrate that dry needling for neuro patients is good enough to be compared. So sometimes it's a bit difficult to understand because when they compare with control, it's fine. But if they compare with dry needling, it's not so good. But apart from all these considerations, I think that we should compare not a single session. We should compare clinical protocols.
Yeah.
And one thing we are adding to this research is a cost-effectiveness analysis because in the end, this is what is really important to compare the cost and the changes for a whole protocol, not just a single session. So it's a very challenging study.
Yes.
And I hope we can overcome all these limitations and difficulties, but we will work hard to
absolutely. I think that's an important point. You know, when you're trying to get something through an ethics committee or a committee at a hospital or a university, that if the hypothesis is proved correct that perhaps dry needling on its own or dry needling with Botox is better than Botox alone, it may save money for the government or the health authority in the future, and of course improve function for the patient. So where money is involved, that usually talks quite a lot.
Yeah, because usually people when we publish things, they look at the effects. But if I would be in a hospital administration, I would check the real cost of all this intervention. And in the cost, we should consider also the adverse effects because you can count the money they cost. So this is something important. It's not just the effects, but also the adverse effects.
Yeah.
That it can involve money.
I mean, function is really important, though, in terms of the patient, but also from a cost factor. If someone is able to look after themselves more, require less help, be less likely to injure themselves because they're more stable, then that's got to be surely a cheaper option than one where they're more likely to injure themselves and so on.
Yeah, I agree with that. And there is also a matter of having the possibility to offer other treatments. Sometimes when you receive a treatment, they let you choose between two. Yeah. So sometimes it will be a good option because of your beliefs or your fears or whatever. So I think that if we can work to offer new treatments, it will always be good.
Okay, just on a side note, I imagine I've worked with a few patients with brain injuries. Quadriplegic patient I treated, I still treat him actually, and they're so grateful. I find that they are really grateful for whatever you can do for them. They're a real pleasure to treat. Is that your experience too?
Yeah, sometimes I feel that they haven't been well treated, or sometimes when they reach some kind of level, they say, oh, you can more or less walk, this is enough, you don't need to go to a physical therapist because you have a brain injury and it's not going to change. Yeah. So sometimes what I understand, like dry needling, is that if we are doing any physical therapy treatment, putting our hands, teaching movement, whatever, I think that dry needling is going to provoke a big effect in biochemically or with electric impulses. So in the tissue, we are going to have very good changes. So I think that we have a lot of opportunities to combine this dry needling, but also I have to say that some neurophysical therapists are a bit reactive to do dry needling because I think they consider the patient so globally, and it's good that sometimes they forget they have a musculoskeletal system and that they have contractors and they can be dry needled to improve the tissue and to improve the function. So sometimes we have also resistances in our profession, I think.
Absolutely. Thank you. That's a great answer. Okay, so let's just go back to some of those patients I mentioned in your videos. Now, how does dry needling work in these patients? Is it going to be any different than working in a musculoskeletal type of patient who comes in with, tennis elbow?
Well, taking into account the evidence available up to date, I can say that the effects may be very similar. The mechanism is very similar when local to musculoskeletal patients, but regarding the central effects is something we can't understand fully now. But what I can summarize is that part of the effects may come from the rupture of this dysfunctional end plate, as this will allow muscle overactivity to decrease. At least for some days. We know that regeneration starts after 3 days approximately, so it may influence the duration of the effects. But apart from these local effects that makes the muscle to relax for some days, we must not forget indirect or central effects, like a stretch reflex modulation and changes at other levels of the central nervous system, as I previously commented regarding this electroencephalographic pilot study. Besides, one important thing that some clinicians don't consider is that the effect doesn't depend only on dry needling. I understand dry needling as a therapeutic window because the immediate effect is so great that this may help the clinician to work intensively with the patient the next day, and also letting the patient has other experiences of movement as some restrictions are disappearing temporarily. So this is a really good opportunity for the patient and for the therapist to work because they have like a time to experience some other possibilities.
Yeah, that's great. I use that a lot when I'm teaching, the phrase a window of opportunity. So what you're providing that patient is a small window to from after treating them to work on more globally, work so that muscles that were related to where you've needled can work better, so that pain may be reduced and therefore they can become stronger or more balanced and so on. It's a really important factor to appreciate when you're doing needling. It's not just about the needling of those muscles. Now,
yes, I agree with
you agree with that, yeah. Okay, so let's ask you this question. How does a person who has spasticity develop trigger points in their muscles? Now, we're aware that, your musculoskeletal type of patient, we know how they get trigger points in their muscles, but is it different for someone with a brain injury or not?
Well, I think that they develop in the same way that musculoskeletal patients, as the trigger point is the same. And I usually receive some questions about the prevalence of trigger points in neuro patients, because people usually in the courses says, do we find a lot of trigger points in neuro patients? How often we are going to find them? So I think I'm going to put some examples to let people listen in the interview to think about this, because we don't have data, but I would like to put some ideas to let people think.
Sure.
So, firstly, for example, we know that when doing repeated movement, this is a factor that provokes trigger points. So, neuro patients, if you think they are always doing the same movements, as they are forced to move into a limited range of pattern of movement. So, we can consider this as repetitive contraction leading to trigger point development. So if we think that somebody who is doing a repeated movement is going to develop trigger points, we can think that in a neuro patient is going to be increase this factor.
Yeah.
So, for example, another one could be that we know that the possibility to develop trigger point also increases when the muscles are contracting in a shortened position. So this also happens much more in neuro patients, or because they are contracting in a very shortened position. So this is also increasing the risk to develop trigger points. We also know that trigger points develop if any muscle imbalances exist, and we can find huge imbalances and coactivation of muscles in neuro patients. So this is another thing to consider Or, for example, when we speak about other causes like compression of trigger point, that we can find that this is also more prevalent in neuro patients, because if we think of a patient sitting for long periods in a chair without changing the position or loading more the unaffected side, we are going to develop more trigger point, and not only in the affected side, but also in the non-affected one. So even if we consider the central causes, so when we speak about the stress may develop or may help to activate or to perpetuate trigger points, if we think in the central nervous system and in the brain damage of these patients, we can also realize that we are going to have a lack of inhibition of these descending impulses. So we are having again a great possibility to develop trigger points. So for me, there is a good question underlying this, and this is also the definition of trigger point, because if people say, okay, there is the same possibilities to develop trigger point, what I ask myself is, okay, but what is a trigger point? Because I think that the clinical definition is very limited, because although I'm sure that I'm applying dry needling to trigger point, this definition is not valid for neuro patients, as they don't feel a tender spot. So you have to consider other criteria that we are using in musculoskeletal patients. So because of that, we base in other indicators such as the volume in superficial muscle, or as I previously told you about the local twitch response. Mm-hmm. So I think that, and I know that this has been a very controversial issue the last time, with some publications criticizing trigger point existence and all these things. So I'm really sure that trigger points exist. I'm really convinced of the effects, but we also have to make also some criticism and to do further research, because if this is an objective phenomenon, it shouldn't be defined only or being only valid regarding musculoskeletal patients. We should define it better to be valid for any type of patient. So this is something we should address in the future, because we need to have a definition valid for any kind of patient. This is my point.
No, that's a good point that you make, because there is a distinction, is what you're saying, between the musculoskeletal patient and someone with a traumatic brain injury, for example, because they're not going to complain of pain in their arm or leg or something. It's more about their function and so on, which is a good point. So I think that the definition of trigger points will evolve like everything else in dry needling. It's an emerging field. But yeah, going back to whether they exist or not, as I mentioned to you before this interview, I was talking to Dr. Salit Jaffrey last week, a researcher from George Mason University, and he says that he's convinced that trigger points do exist. I don't think that there's any doubt in his mind about that, and came up with many of the reasons or the etiologies that you've mentioned as possible causes of trigger points in a patient with a traumatic brain injury. So I think we're on the right track. We just got to evolve, and with time, keep open minds and continue to do more research. As the phrase is often said, more research needs to be done.
Yes, I read his paper, and I also had the opportunity to attend a conference organized by Myopain seminars with Jan Domerol, and it was really interesting, everything he was explaining, because I think he's going deep into the real mechanisms of trigger points, and this is the work we have to do. If we really want to say objectively what is a trigger point, we want to measure. So I think he's really doing a good job, and I really love to hear his presentation and to read the paper. Although when I read it, I have to say that some parts are really complicated.
Yes.
I struggle with biochemicals, so I read again and again. Sometimes it's very difficult to get to this depth of knowledge as this man has. So, but this is a good work to have people like him working on this.
Absolutely. You made me feel better, Pablo, because every time I did a lot of research for that interview that I did with him last week, and I had to have a lie down and rest after every paragraph. And then I had to be very clear about my questions to him. But he's a very smart man. His CV is 52 pages long. So that gives you an impression of the man's intellect. But anyway, he's a lovely chap, really down to earth, and very, very knowledgeable about this subject. So let's go on to another question. How long can the responses last? So we saw the two videos, or spoke about the two videos with the two ladies with the milk bottle and the gait and the walking in the corridor. Do you see responses that can last for long periods of time, or do you treat these patients in the same way that you would treat a musculoskeletal patient? Say, well, I need to see you next week, or 5 times for 5 weeks, or whatever. How long do you see the changes lasting for?
Well, this is a very good question because it depends on any patient, really. So the effects, in my mind, will depend on biological and central effects, as I previously introduced. So I think that some example also will help now. Sometimes, for example, we find a patient that is not going to collaborate because of cognitive limitation, and this patient will depend more on this biological effects because the patient cannot do any activity, any cognitive activity, active activity. So what I mean is that if he has a high activity coming from upper levels of the central nervous system, the effects will last about 3 days or a bit more because reinnervation occurs and active therapy is not possible for the patient. So we can say that the patient is going to be very dependent on the biological effects. So perhaps this patient is a patient that we can treat once weekly, more or less, to respect the reparation of the end plate areas. But however, effects may last longer or help other treatment. For example, if it's combined with other treatment like orthosis, it may help or it may last more. So again, we shouldn't consider dry needling isolatedly in this patient. But, for example, the opposite case would be a patient with a high functional level with not a lot of spasticity or biological component or high activity coming from upper levels. So the treatment will last more as he doesn't have so much activity. And besides, as it has good function and cognitive skills, he's going to integrate better the changes leading to new patterns of movement. And besides, if combined with other physical therapy treatments, they are going to benefit much more. So there are 2 points here. One is that dry needling is not always acting alone. And the other is that if you have a higher level of function or cognitive skills, you are going to benefit much more because of the rest of the treatment, because you can integrate more.
Okay, so that's interesting. But moving on from how often you treat them and so on, the changes that you get, the functional changes, what are they? I mean, what can they do better following dry needling in a functional perspective?
Well, for example, it depends mainly on the objectives. For example, if I would be treating the first patient, sometimes I do just dry needling to decrease activity, to wear orthosis, to let him feel a bit more relaxed. But when we move to these more functional patients, we try to analyze which muscles are interacting more. So we do dry needling, and we usually ask them to come at the beginning. They come after 1 week or a bit more. So we check if the changes are maintained, because sometimes if they do active things, they can maintain these changes. Mm-hmm. And sometimes, for example, I had a case of spastic paraparesia, and it was very good to see this girl, because I started to treat, for example, the hamstrings because it has a limited extension of the knee. Mm-hmm. But after one session, he was standing perfectly, and the problem for her was that she was feeling some imbalances when putting the foot. So as the pattern changed, there were appearing some other things. So I did another treatment, but only for tibialis posterior or flexor digitorum. So the next session, she told me it was very good because we also made some eccentric exercises to reinforce this muscle. And for example, it was a very good result, but she told me that now it was really good, but she felt like a grasp in the sole. So I checked, and it was just related to the flexor digitorum brevis in the foot. Mm-hmm. So I did drain needling there, so it also improves. So what I want to say is that sometimes it's really dynamic, so it depends on the patient. So patient with a very high function, it has more possibilities to be more changing or more dynamic, but sometimes people with a big contracture or very affected, this is like a treatment to maintain, to avoid some other adverse effects, I think.
Okay. So that's great. Now, looking at wider outlook here, and if you're looking at if dry needling was adopted more commonly in the healthcare setting with these patient groups, then the money and the healthcare burden can be saved by reducing the cost of help and support for these patients. What do you think that's going to be a strong argument? Do you think that's going to be something that is going to push your case for allowing or integrating dry needling into the treatment of these patients?
Yes, I'm sort of this because currently the economical issues are very important. But apart from economical consideration of dry needling, I think that having another alternative to offer to patients is important. And sometimes patients prefer dry needling to other treatments like injection because of their beliefs or previous experiences. So because of this, we are trying, as I told you, to do a cost effectiveness study to be able to tell the authorities that we can save money, or at least to put numbers to what we think, because perhaps we can be confused and it's not so cheap because we need many more sessions. But sometimes these studies needs to address the number of sessions, the real effects at different points of the study, to define which protocol could be better from a cost effectiveness study, but also to consider if there are some adverse effects because they cost money. So, and apart from that, they are affecting people. So this is something important, not only economically, because if you have adverse effects, although they are not very big, you are treating people. So this is something also to consider, I think, and sometimes this is not very considered from this medical perspective, I think.
Yeah, no, you're absolutely right. You've told us about the research that is important to do in the future. Tell us about some of the research that you've done in this area so far.
Well, I come from the clinical setting, so because I've been working for the Spanish government as a clinician until 2009. So I'm relatively very young for research, so I'm making a great effort, and also my research group are people with which is very young, but we are really encouraged to change things and to have a very good clinical approach, because all of us combine the research and the lectures with clinical. So, for example, I treat patients 10 hours a week, more or less. Mm-hmm. So I think this is also going to give us a good clinical approach to change some things. So, although we don't have a lot of things published up to now, what we have is 3 studies under review of electroencephalographic activity, only in 2 patients. Okay. Another is a case study about the measurement of dry needling spasticity with or the resistance of movement, or how you want to call it, with attention myography, because we want to really measure the changes in the muscle, the contractive properties of the muscle. And the other is a pilot study about upper limb function, but they are still under review, so I hope they can be for the end of this year. But apart from this study, we have started some others. So, for example, as I told you, we are doing a study of brain healing in rats with spasticity in Mexico, because we want to know if rats behave in different way, if they are with a normal central nervous system or with spasticity, because perhaps this allow us to infer some conclusion for patients. Or we are also measuring neurophysiological variables like stretch reflex to try to understand which are the underlying mechanisms of brain healing in neuro patients. We recently had a publication in Pain about pain thresholds, and we are also starting this in neuro patients because we don't know many things about pain thresholds and the sensory profile of neuro patients. So this is also a good line. And also the key study for me is this comparing botulinum toxin, because I think that if we can work seriously comparing botulinum toxin and studying the cost, this can involve a real change in the clinical practice. So I'm really committed to do this study, although we are finding some resistances, as I told you.
Well, that's great. It's very exciting. And as you say, you're a young man. You've got many years ahead of you. So looking forward to hearing more about your research. It is a very exciting field to be involved in, and to hear that dry needling might be able to help so many people that don't really have a lot of other options as far as treatment goes, not many choices, as you say. Where do you see your work going over the next 5 years? What are your aims and goals for DNHS?
Well, my aim is twofold. So I consider my perspective as researcher, but also as clinician. So as a researcher, I want to know how dry needling is working to design better protocols. So all these studies about the neurophysiology, the mechanisms underlying dry needling, and also compare its clinical effectiveness and cost with other existing therapies as botulinum toxin, as I think this can be a very worthy options for many patients. But on the other hand, as a clinician, when I'm treating patients, this always helps me to reconsider my way of thinking, because sometimes you find something you don't expect, and we have to be open-minded to try to take this clinical experience to research and solve these questions. So I have some perspectives, but my daily life will give you more clues or more ideas to orientate this research. So one of my objectives would be that also a lot of people in the world could be trained in this specific area, so they could offer their patient a good treatment and also encourage them to work together to develop more research in this area. Because as I always say in my courses, I try to encourage them or give the opportunity to do research to clinicians, because usually people attending the courses are clinicians and they can treat a lot of patients. So sometimes I think the challenge is to mix clinicians treating patients properly and with a good protocol, and researchers on the other side supporting, writing, designing, doing statistics, all this stuff that clinicians don't usually like a lot. So because of that, I created this international research group, because I take the opportunity to invite people when I go to different countries. And this has been working well in some countries like Mexico. And I hope that possibly in Kuwait, as I have also a PhD student from there. So I think that we have to mix clinical and research point of view. So this is my way of thinking.
Yes, that's very forward thinking, a great vision to have, Pablo. Well, look, thank you so much for your time today, Pablo. I know that you've provided us with some great insights, a lot of information, a lot of technical knowledge, and your time, of course. So I'd like to take this opportunity to thank you for this interview and to wish you well and every success in your clinical work and, of course, in your research. Pablo, thank you very much.
Well, thanks to you. I really learned a lot from this interview, as you made me think and put some of my thoughts in order. So I really appreciate it. Thanks very much. And I hope we can see in future years and we can say how things have changed so much, or how perhaps some of our thoughts were not appropriate. And because this is what it has research, you have to check things, you have to have new ideas. So I think we have to be open-minded and to be also very critical with ourselves. So I think this is also a good opportunity to have this interview and also be contacted with English speakers, because I have a lot of influence in Spanish-speaking countries, but when I moved to English countries, now I feel a bit more fluent with my English. But when I started, I was struggling. Although you have realized on my Spanish accent, isn't it?
No, look, I can honestly say that your English is much better than my Spanish. So you, all the Europeans, I was brought up in the UK, and all the Europeans across the channel speak more than one language. And embarrassingly, I can only speak English and Arabic, but not any European language. So you've done very well, and I'm sure that you will go on to influence more people in the English-speaking world.
Okay, thanks very much.
Thank you, Pablo, and good night. That was Dr. Pablo Herrero talking with me about dry needling for spasticity and hypertonia. If you'd like to get access to the rest of this podcast, plus other great interviews with world experts in the area of dry needling and myofascial pain, please log into your account at members.cpdhealthcourses.com/login. Now, if you're not a member, I encourage you to join the CPD Health Courses membership site, which gives you access to hundreds of hours of content, including over 60 hours of dry needling video training, business coaching advice, useful documents like dry needling consent forms, and even staff training scripts, plus a lot more relevant content that's available as online programs to listen to at any time or downloadable PDFs. And in addition to these resources, I'm available on the membership site too. I'll answer any questions that you might have about clinical practice and running your healthcare business. If you'd like to join the membership site, please visit cpdhc.com/video training. Membership is either monthly or annual. My advice is to get the annual membership price, which gives you a great discount on the monthly subscription. So visit cpdhc.com/video training to find out more. I look forward to seeing you on the membership site and helping you achieve your goals as a healthcare practitioner. I'm Wael Mahmoud, and you've been listening to a cpdhealthcourses.com podcast. Thank you for listening.
CPD Health Courses. Dry needling training for health professionals.